Morning. Good morning, good afternoon, and welcome to the third webinar of our series on disability inclusive social protection. Today, we are going to focus on social health protection for persons with disability to ensure equity in health for all. My name is Marielle Fegoursa. I'm a regional project manager at the ILO Regional Office for Asia and the Pacific, specializing in social health protection. I will be your moderator for today's webinar, along with my colleague, Yuta Momose. If you have attended the previous webinars, next please, you already know this series is organized by UNICEF, the ILO, and IDA with the support of many other development partners. This series aims at promoting and also disseminating knowledge on the core modules of a guidance note that has been developed with the objective to facilitate the design of disability inclusive social protection. Next, please. This webinar is going to provide key insight into the access to social health protection for persons with disabilities. The aim is to explore the essential role that social health protection plays in delivering healthcare without financial hardship, and particularly to address the higher and the specific needs of persons with disability, including assistive devices and other associated costs. So the discussion will address current gaps and propose ways to design and implement social health protection systems that are disability inclusive. This webinar is being recorded, and the recording will be made available on the website of socialprotection.org, along with the other recording of the previous sessions. Automatic captioning is activated, and international sign language interpretation is provided throughout the webinar. Please also note that simultaneous interpretation is available in English, Khmer, Lao, and Vietnamese. So if you wish to listen to the interpretation, please, in your Zoom controls, click on interpretation and select the language that you would like to hear. So moving on to the agenda, we will start with a short introduction from Deputy Director of the ILO Regional Office for Asia and the Pacific. It will be followed by a presentation on what disability inclusive social health protection is about, as well as a finding from a regional research in Asia on access to social health protection for persons with disabilities. Then panelists from Cambodia, Laos, PDR, and Vietnam will share additional insights on progress and remaining coverage gaps and how this can be addressed with adequate policies. Next, Australia National University will share experience on a national personalized disability support scheme. And finally, UNICEF will suggest strategies and ways social protection can facilitate access to assistive technology. And that will be followed by an intervention from the ASEAN Disability Forum to share insight on that topic before we open the floor for questions and answers. In the meantime, you can use the chat box to present yourself, make comments, share useful links. You can also share your questions with the speakers using the Q&A box. So this is important. Please use the Q&A box, otherwise we will not get your questions. Please specify your name and organization, and if your question is directed to a specific speaker, so we can more easily address your question. You can also comment the session on X using the hashtag SPORG-webinar and the hashtag disability series. So can you please mute?
It's just presenting the process.
Yeah.
Please, okay, I think someone mute me. I'm unmute now. So who are the speakers today? Next slide, please. You will probably recognize some familiar faces. To start with, we will have Panudda Boonpala, who is the Deputy Director of the Regional Office of the ILO in Asia and the Pacific. Her many years of experience at leadership positions cover several areas of work, including social protection. Then we will welcome Charles Knox-Vydmanov, independent consultant specializing on social protection and disability. He is the lead researcher of the ILO study that will be presented in a few minutes. Our panel will include brilliant researchers from Asia, researchers who have led the country case of that same study. We will have Nguyen Can Phong, Director of the Health Strategy and Policy Institute of Vietnam, and a lead health economist with more than 25 years of experience in the topic. Ket Boravin is a researcher at Agile, a research organization based in Cambodia. His work focuses on fostering economic empowerment for people with disability. Ms. Ketmani Shantakuman is a deputy head of the Division of Health Policy and Health System Research at the Lao Tropical and Public Health Institute. Then we will also have the honor to listen to Kristen Phillips, professor at the Australia National University. Christine has a specific expertise in anthropology, medicine, and public health, and led several researches on equity in policy and practice in complex health innovation. She will be followed by an intervention from Alexandre Cotte, social policy specialist at UNICEF, who maybe need no introduction when it comes to the field of disability inclusive social protection. Finally, we will listen to Lim Poitiak, chairman and founding members of ASEAN Disability Forum, and is also a board member of IDA. So warm welcome to all. And without further ado, as we have a busy agenda, I would like to invite Kun Panudda Boonpala for sharing her opening remarks. Thank you very much. Kun.
Thank you so much, Maria. Good afternoon, everyone. We're in Southeast Asia time zone. Good morning and good evening for those who are in other parts of the region. I'm really delighted that we at the ILO have the opportunity to co-organize this important webinar on social health protection for persons with disabilities in Asia, in partnership with UNICEF, the Connect Network, and the P4H Network. This webinar, as Maria mentioned, builds on several years of fruitful collaboration with national research institutions and organizations of persons with disabilities. Today's webinar marks an important step forward in our commitment to ensuring no one is left behind. The findings we will discuss today are the combination of a year of extensive field research and collaboration aimed at addressing the barriers and gaps in social health protection for persons with disabilities in Southeast Asia. At the ILO, we emphasize the importance of a universal approach to social protection. The objective is to ensure that everyone has access to comprehensive, adequate, and sustainable income protection and healthcare throughout their life. This is in line with international labor standards. Social health protection enables people to access the healthcare services they need without financial hardship. It protects them against the risk of impoverishment resulting from out-of-pocket health spendings. This is crucial for poverty reduction and ensuring good health for all. In 2021, the ILO and the Connect Network published a landmark report on the state of social health protection in Asia, highlighting both challenges and opportunities. Since then, our efforts have focused on extending social health protection to vulnerable groups, including persons with disabilities, the elderly, migrant workers, and domestic workers. Despite progress in Asia and the Pacific, significant gaps remain. Only 63% of the population in the region is protected by a healthcare scheme, leaving about 1.6 billion people wholly unprotected. Although comprehensive statistics are lacking, evidence shows that persons with disability are more likely to suffer impoverishment caused by healthcare spending. Also, persons with disabilities are estimated to be over 650 million in Asia, representing 60% of the global number of persons with disabilities. The needs of persons with disability are diverse due to varying circumstances and environmental barriers, as well as the different types of disability. Because of this complexity, policies on disability social protection and social health protection are often discussed separately within different ministries, leading to overlooked needs. To provide adequate protection to persons with disabilities, comprehensive disability inclusive social protection policies are essential. First, this policy should include disability cash benefits to ensure income security and cover disability-related extra costs. However, cash alone is not enough. As we will discuss today, financial protection must also be provided for access to healthcare, rehabilitation, assistive devices, and personal assistance. Second, these policies must be designed in a way that adhere to international human rights principles, aligning with the UN Convention on the Rights of Persons with Disabilities, the Incheon Strategy, and the ILO standards on social protection. Finally, inclusion of people with disabilities in social health protection requires their direct involvement and the participation of organizations representing them in the planning, implementation, and monitoring of social protection policies. We are pleased today that several OPDs have participated in this research and are here at this webinar to provide insights and reflect their actual voices and needs. The presentations we will hear today show that significant legal and operational gaps remain in social health protection coverage. Urgent action is needed if we are to achieve universal health coverage for persons with disabilities by 2030. I'd like to thank the institutions that implemented and supported our research in various countries, including the Laos Tropical and Public Health Institute, the Vietnam Health Strategy and Policy Institute, the Cambodia Agile Research Group, and Seoul National University. Finally, I'd like to extend special thanks to Australian National University, the UNICEF, ASEAN Disability Forum, and all of you who are here today. I wish you all a very productive and interesting, insightful discussion. Thank you very much. Thank you for your attention.
Thank you very much, Deputy Director, for your opening. And I suggest we dive directly into the discussion. And since I'm on the floor, I will start by briefly introducing the topic. The presentation will show very soon. Thank you very much. Next, please. So why do we want a particular attention on that topic? First of all, because health is a human right, as we know all. But the reality is that persons with disabilities are facing more acute challenges than persons without disability to realize this right. Why so? First of all, because persons with disability often, not always, but often face a greater need for healthcare. They tend to be poorer than the general population and are on average older, especially in Asia, which increases the likeliness of diseases. They also face greater barriers to access healthcare services. They are often exposed to discriminatory practices. They also often lack knowledge on the care they need and how to access them. And the information that they may need is not necessarily available in a format that they could access. And finally, they are also facing greater cost to access healthcare, direct or indirect, medical or not, particularly in relation to the loss of income and the time spent to access services for themselves or for the caretaker that is coming with them. Next, please. So as a result of their multiple needs and lack of protection, half of people with disabilities cannot afford healthcare. And statistics show that they are about 50% more likely to experience catastrophic health expenditure, as it was mentioned earlier on in the opening remarks. So the question is, how do we address those gaps? How do we address the life cycle needs of persons with disability in a way that comply with a social and a human approach, addressing barriers, but also promoting inclusions? So we can start by designing and implementing disability inclusive social health protection policies and systems. Health, in the next slide, health protection is, as you know, one element of a comprehensive social protection system that is disability inclusive. It's one element that go along with income security, coverage of disability-related costs, and access to early childhood development, education, and also economic empowerment programs. So when it comes to health in particular, there is a number of good principles that must be followed to make protection inclusive. So what are these principles? They can be illustrated using the usual 4 dimensions of social health protection. Next, please. This is first population coverage. So when we consider population coverage, we must make sure that all persons with disability are covered. That's universal coverage. That must be both legal and effective, and made possible with the provision of full or partial subsidies from the state. It also means on the dimension of service coverage that the system must cover a comprehensive range of health services and not exclude rehabilitative services and assistive devices. On the financial protection dimension, it means that there should be no co-payments, and benefit packages should be progressively extended to include direct, non-medical, and indirect costs as well. And finally, when it comes to the quality of services, services should be available, which is not necessarily the case, particularly when we talk about rehabilitation. These services should be accessible regardless of the type of disability, and it should be acceptable. And that particularly means that the services should be provided without any discrimination. So with this quick introduction, I would like now to turn to Charles, who has led together with the national research institutions, the ILO study that takes stock on the achievement of Cambodia, Laos, PDR, and Vietnam along these 4 dimensions. Charles, I give you the floor now. Thank you.
Yeah, I assume everyone can hear me well. Just to say hello to everyone. And yeah, it's great to see such a wide participation in the session. So many participants from across the world, including some familiar names within there and some that were involved in the research. And maybe just to say on the kind of geography, while we are focusing on the 3 countries here, I think the kind of lessons and some of the messages and some of the thinking can be quite useful for kind of comparison across countries, and even thinking about how to look at systems in other countries across the world, because I think you'll see many of the issues are quite common in many respects. So just to explain this piece of research, what was the kind of methodology, the approach that was taken? I mean, as you know, we're focusing on these 3 countries, Cambodia, Laos, PDR, and Vietnam. In a way, quite interesting to be looking at 3 countries which are in a very kind of similar geography, have some similarities or shared elements of their history. But then I think, as we see, there are quite different pictures in terms of how the health systems are developing and how the accessibility for persons with disabilities. I mean, I've put the objective there, and I guess just to kind of summarize, what we were really trying to look at is very much answer questions around access of persons with disabilities to healthcare, keeping in mind particularly those kind of three dimensions, main dimensions of the UHC, Universal Health Coverage Cube, that are often referred to. So kind of population coverage, to what extent are persons with disabilities members or kind of covered by different kinds of health protection, health insurance schemes. To what extent do those schemes in particular, or more broadly, provide appropriate services, particularly keeping in mind those that are of particular relevance to persons with disabilities, such as rehabilitation and the provision of assistive devices, but also not just thinking about that. And then finally considering the level of financial protection that those schemes and broader systems provide, the kind of costs that persons with disabilities may have to incur when accessing healthcare. And then there's a kind of fourth dimension that I'll refer to, which we tried to explore, which is about long-term care services, or sometimes called care and support services, so other kinds of services that may be required and sometimes provided for persons with disabilities that sometimes can be considered part of the health service package. Now that's slightly separate in the kind of analysis, partly because in fact those systems are quite underdeveloped and are not yet within those health system and health protection packages. But we tried to explore a little bit, okay, well, what's the situation there? In terms of the methodology, the focus was really on qualitative research. So that included quite a large number of focus group discussions with nearly 300 participants. And that was divided by type of impairment. So, some with people with physical impairment, some visual, some intellectual, some hearing impairments. We also tried to pull out, in some cases, the experience of caregivers as well. And we had also over 40 key informant interviews with different levels of government, and also with organizations of persons with disabilities and other service delivery organizations such as rehabilitation centers. We combine this with a review of the legal framework and of existing research. So where possible, we've tried to bring in other analysis that's already been done, and try and complement this analysis and see what the broader picture that is saying, and also draw on existing data sources where they've existed, where there have been surveys undertaken that have useful analysis. We tried to bring that in, but there hasn't been we haven't done new quantitative analysis in this case. To go through the findings, I'm going to start by looking at population coverage, then the service coverage, then the financial protections, those kind of three dimensions. Then I'm going to talk about this question of care and support services and long-term care. Now, thinking about population coverage, it's useful to start by trying to get a sense of, well, what are the different schemes and systems in place? What are the different channels through which, potential pathways, you could say, through which a person with disability can be covered by different kinds of schemes that may exist? Now, my caveat here is just to say these systems are more complicated than what I'm going to share here, but there is a general kind of simplified picture, which I think helps us understand what's available across the three countries. So I'm kind of mapping out the different schemes that are available. So all three countries have different kind of social insurance-based, social health insurance-based schemes through their social security schemes that are in place, and where those that are actively contributing to those schemes or are recipients of other social security benefits, pensions, work injury, those people are covered by health insurance to different degrees. Now, I should mention that though the countries vary in the extent to which they've gone, say, beyond those in the kind of formal economy and have been seeking to expand coverage through, say, subsidized schemes. But all of them have a scheme of this nature in place. So that's one channel through which persons with disabilities can potentially access social health protection. The caveat obviously being, as we know, persons with disabilities generally have lower levels of employment, are more likely to be in informal employment and so their likelihood of accessing those schemes is generally lower. Now, drilling down on one country, how's Vietnam gone about extending social health insurance, social health protection coverage? Now, this is one country that has a very clear disability-specific component. The there's a disability allowance in Vietnam, which is for persons who are assessed as having severe or extremely severe levels of disability through a disability assessment. Now, in extending social health insurance, the Vietnam government included those receiving an allowance in the social health insurance package. So they are by default included, alongside those receiving other social allowances, which can relate to many different kind of groups. One includes old age, and that's quite relevant in relation to disability, because I think what you find is some persons with disabilities are covered via that kind of receiving the old age allowance, not just through the disability allowance. There are also various other kinds of subsidized groups that that are included in Vietnam, which include different members of different government staff and employees, poor households. As I mentioned, there are different kinds of subsidized contributory arrangements for various different groups, and it's quite complicated, and there's more about that in the report when it will be published. But let's move on to Cambodia. How does Cambodia differ? Well, the main other scheme that is in place in Cambodia is the Health Equity Fund, which is a scheme that is targeted towards those with an ID poor card, so those that have been assessed as either poor or living in near poor households, and have been targeted as such using a proxy means tested approach. So that's the main kind of scheme alongside the contributory National Social Security Fund. An interesting thing which we'll continue to discuss a bit in this session is also Cambodia has recently rolled out a disability card with a new disability assessment, reaching 300,000 persons with disabilities now. And there's some sense or understanding or assumption or presumption that that provides access to free healthcare. And what we see is some people are accessing free healthcare through that scheme. However, it's still actually a bit ambiguous how formally established that entitlement is. So what about Lao PDR? I mean, the main situation in Lao PDR is that in addition to this contributory scheme, quite recently, in the last few years, the country has established a national health insurance scheme, which basically provides health insurance coverage to everybody who's not covered by any other kind of scheme. They don't have a card, aren't formally registered. There isn't a kind of formal application processes, but by default, if they go with a family book or an ID card to a health center, hospital, they should legally, in theory, be covered. So just then to kind of summarize, what does this mean in terms of coverage across the three countries? This is for all people, not specifically for persons with disabilities yet. What does that mean in terms of coverage? Well, what we find is Vietnam and Laos, according to official figures, legally, more than 90% of the population is covered by different kind of health insurance arrangements. In Vietnam, that means 93% actually have a health insurance card. It's a bit more ambiguous in Laos, as I mentioned. In Cambodia, the latest figures suggest across the population as a whole, it's more like 40%, though that doesn't account for the disability card. So that's the broader context, and that before we've got into the disabilities side of things. So what do we see when we actually explore some of the data and discuss with persons with disabilities? I mean, I think a key message is countries that are moving towards universal health coverage and trying to expand universal population coverage through whatever means. I mean, that's something that is conducive to persons with disabilities, and is more, a country in that process is more likely to achieve higher levels of coverage. So that's an important precondition. However, within that, having subsidized and kind of non-contributory components or elements to a social health protection or social health insurance scheme can be particularly key for people with disabilities. And what the data to the right basically shows from Cambodia is that persons with disabilities are a lot more likely to be covered by the non-contributory component, the health equity fund via the ID poor system, than they are via the contributory channel, which is through the National Social Security Fund. And this is something that one sees many countries, similar data coming out as well in Vietnam, that these kind of tax finance non-contributory elements within a social health insurance scheme are really critical for persons with disabilities. I think this is reflected across the world as well. So yeah, as I've mentioned, those disability-specific components as well, those subsidized components such as the scheme for, or the element for persons with severe and extremely severe disabilities in Vietnam, and this new disability card in Cambodia can be really key for, in that process of extending coverage, ensuring persons with disabilities are perhaps prioritized or reached first or included in that process early. Now, a key factor in that is the nature and effectiveness of disability and assessment and determination systems, which is something that is being covered and discussed, I think, quite a lot in this broader webinar series. What I would emphasize, I think this is a thing to kind of note and look into, those of you who are working across the globe, Cambodia and Vietnam have been, I would say, quite ahead of the curve in terms of building systems of disability assessment that have moved away from a purely medical model, trying to bring in the more kind of social aspects of participation of persons with disabilities, also more community-based models, which are more accessible for persons with disabilities. They haven't necessarily got everything right, but I think these are two interesting countries to study and look at in terms of those that have made good progress in that space. It's just a few kind of voices and testimonies from across the three countries. So on the question of disability assessment, the general picture in Vietnam was that the system was perceived to be relatively simple and straightforward to access. People generally saying it's not so difficult. And they were guided through the process. So some positive elements there. The caveat is that I think the locations we were looking at in Vietnam were not the most remote areas where there are potentially greater challenges to accessing that system. So that does require, I think, a bit more investigation. In Cambodia, I think a couple of elements that are important to note. So as we say, the ID Poor Card system and the Health Equity Fund has probably disproportionately reach persons with disabilities, despite not really being specifically adapted to disability. However, you know, many persons with disabilities are not included in that, have not been included in that system. By its nature, it targets only poor households. And as I mentioned, there's this question of the disability card, this new card that's been rolled out. The entitlements are quite unclear. So there was actually a bit of a mix between people saying, as here, you know, the health staff don't acknowledge this this card, and people actually saying, oh no, I did go, and maybe there was some confusion at the hospital, but eventually I was provided access to free healthcare using this disability card. And a final point on Lao PDR is that you know, persons with disabilities, in fact, a very important point I failed to mention, the National Health Insurance scheme in Lao PDR only applies outside Vientiane, so it does not apply in the capital. But when we look outside, and we in the kind of the areas outside the capital, one finds people with persons generally, quite a few have been accessing services using that scheme, where they only have to make a small co-payment. However, the scheme isn't all that well understood. People don't even necessarily know it's called the National Health Insurance. It's a relatively new scheme, and the information understanding is limited. So those are some top line elements there. Just to emphasize as well, I hope that some of these points we can dig into in a bit more detail in a few minutes when we hear the voices of the researchers who were really deep in the analysis in the three countries. So what about service coverage? And we can kind of divide this into two areas, as I think one tends to conceptually. Firstly, there's a question of persons with disabilities accessing general goods and services that aren't necessarily related to their impairment, their disability. And the second is those more kind of directly disability related services. So first, on those general goods and services, which often persons with disabilities are requiring more than those without, is a general trend. It's important to note that there are often exclusions within these social health insurance packages, or there are certain medicines, treatments that require a co-payment or a higher co-payment for those goods and services. And that was something that one sees in the first testimony, highlights there across the three countries. So in the case of Vietnam, you know, certain treatments were covered, but other things were not covered, and individuals had to pay when accessing healthcare. I think the understanding of what is and what is not covered is not that great amongst persons with disabilities or the population more generally. Now, thinking about those more directly disability-related services, not necessarily disability-specific, but things such as rehabilitation and assisted devices, which are particularly relevant for persons with disabilities. I think you can categorize the countries into two. So in Vietnam, you have a situation where rehabilitation in particular has been gradually integrated within the social health insurance package. And there's been a gradual increase in the services covered. However, there's still some quite important gaps in that respect. And assistive devices in particular, particularly things like prosthetics, are not generally covered under that system. And some of the second testimony there points a little bit to that, and only some services being covered, others have to be paid out of pocket. Now, Cambodia and Laos are really a distinct situation where rehabilitation services and assistive devices are not really included in social health insurance packages. And really the provision is in a kind of parallel channel via rehabilitation centers, often called physical rehabilitation centers, that run, as I say, almost separately. There's limited referral and kind of channeling people between the health system and between those rehabilitation centers. Often those centers have a history of being developed, particularly in these two countries, in the context of concerns and responses to the high levels of unexploded ordnance. Often they've been heavily dependent on donor and international organization funding, though there's a kind of mixed picture in that respect. But as I say, that's mainly separately. And the availability is highly dependent on geography, whether people live near to those centers, information, whether people know about the availability of those services, and funding. And in both Cambodia and Lao PDR, you get this sense that, well, if there's been a project or funding available or particular kind of, provision or the kind of import of certain assistive devices by an international organization, well, then there's been that availability. But if not, there hasn't, and this thing changes over time. Interestingly, I think there are moves in both countries to better integrate those systems, those kind of centers within the health system. So what about
sorry, Charles,
yes.
3 minutes. Thank you.
Yeah. No, I realize. Okay. Oh yeah, I missed a slide. Okay. Well, on that basis, I'll try and summarize briefly the last few points. But yeah, okay. In terms of financial protection, I think what I'll kind of summarize here is that there's a mix of both medical and non-medical costs that are faced by persons with disabilities. I mean, the medical costs a lot relate to what I've discussed already, the gaps in coverage, the gaps in services coverage, potential co-payments. Often due to quality and accessibility issues, people are using private healthcare facilities or pharmacies. In terms of kind of non-medical costs, then it's the questions of the cost of transportation to health services, the cost often of human assistance, so support by family members, friends, and sign language interpreters to access health services, inpatient related costs, and also opportunity costs. So the cost for a person with disabilities or those that support of having to, say, not work that day or lose a day of work or have to or you forego kind of caring responsibilities. And this is just a summary of some of those kind of testimonies. What you see is there, I think across the three countries, a positive impact of those social health protection schemes where they've been in place for covering those costs. But as I say, these issues of some costs aren't covered. There's a tendency sometimes to use private healthcare facilities, the non-medical costs. And the last one maybe to highlight, often people having to, the coping strategies for this being quite significant, problematic, having to use savings, having to borrow money, for example, look to families for support. And I mean, one important element of dimension of financial protection is what is the role of cash benefits across the different countries. I think one can say this has a potential role to play, particularly in terms of those non-medical costs, which are less likely to be covered by different social health insurance arrangements. The issue of so different kinds of cash benefits exist in Cambodia and Vietnam. It's quite a mixed, quite a complex picture. I think the big challenge that's indicated on the figure to the right is the benefit levels in both countries remain quite low by international standards, which is one indicator of the limits that they can play in covering some of those costs. Finally, really, in terms of long-term care, I mean, the first point here is really just to say care and support needs vary considerably among persons with disability based on the nature of impairments, various intersecting factors, which I think will be familiar to many of those here. So whether a person needs, you know, significant human assistance or needs, say, assistance to visit health facilities or to go shopping or to the market, these are the kind of care and support requirements vary a lot. And really, I'll simplify, but the big picture here is that both at a kind of legal level and at a service provision level, the long-term care, as we call it, or care and support services are very, very limited across the three countries. So I'm a little bit over time, so I'll just summarize this very quickly, not least because I think I've kind of summarized these key points. But to highlight the key messages coming through, okay, population coverage within a broader strategy pursuit of universal health coverage, there's a key role for disability-specific components to expand coverage within the social health insurance packages. And disability assessment, determination, certification is going to be a key part of that. Service coverage, there's a key need, I think, to include rehabilitation assistive devices within social health protection benefit packages. One can also consider perhaps custom and specific benefit packages for persons with disabilities. That's something that I think will be discussed later in this session. Again, on financial protection, one can look at specific measures, reduced co-payments, for example, and cash benefits can play a really, really key role to cover particularly non-medical costs. And finally, I think really the on the long-term care or care and support services, this is something I think, you know, countries need to, there's a strong call for the need to start building those systems, start thinking about how they're going to build them, what models they're going to take, how they can be built over time. And worth in that process, thinking how they integrate with the health system and also the linkages between disability and old age, which are sometimes in those systems treated separately, which is not always the best thing. So I will leave it there, and I think we'll go back to Marielle, but I'm looking forward to hearing some of the questions, which I'll look at on the chat as well.
Excellent, and thank you very much, Charles, for the presentation. Let me now welcome our panelists and get their additional insight from the field work they have done. So I will start with you, Dr. Phuong from Vietnam. Dr. Phuong, can you hear me?
Yes.
Yeah,
Hi.
thank you. Welcome.
Yeah.
So we will start our first round of questions around population coverage and financial protection for persons with disability. So we know that Vietnam is one of these countries in Asia that has made significant progress in extending health insurance coverage to more than 90% of the population now over the recent years. Can you tell us a bit more about how this achievement have benefited to persons with disability and to protect them better when accessing healthcare?
Yeah, thanks, Mario, and thank you, and thanks, Chat, for a very brief but informative presentation on the key finding from the study in 3 countries. From Vietnam, we are proud of with the achievement of the expansion of the social health insurance in country. Recently we have the 93% of population covered by the social health insurance, public that is public health insurance program subsidized by the government. So we have the policy of the universal health insurance strategy to achieve the goal of the universal coverage of the healthcare for the people. So there is a significant support, the commitment, financial commitment, support from the government to subsidize certain group of people to be eligible to the social health insurance member, of which there is the disability, the people with the disability of the extreme, severe, and the severe level. So based on classification of the people having the extreme, severe, or the severe level of disability, so these people will be provided social health insurance card member card, so they can eligible to own the benefit package under the social health insurance, which is quite inclusive and generous, including the medical service and the medicine provided under the social health insurance scheme. So I think that in terms of the population coverage, Vietnam, with the government commitment and the government subsidy, so there is a quite favorable the achievement and the condition for the benefit, significant benefit for the people with disability. Just for some detailed information. So in the estimated figure, we have the totally about the 7 million of the people with the disability, of which about 1.6 million classified at the extreme severe or the severe disability level of disability. So that the remaining is all the mild disability or the unclassified yet. So that is just some piece of information for you, your reference. Yeah.
Thank you, Dr. Fong, for this insight. So different entry point in the system and including specific policy measures to make sure that persons with disability, with severe disability, do not pay their contribution and enjoy a waiver on the co-payment, right? Thank you for your insight. And I have a similar question for Dr. Ketmani in Lao PDR. So Lao PDR has also achieved a legal health insurance coverage of about 94% of the population now through essentially a policy of subsidies for the persons who are not contributing to the LSSO, the Lao Social Security system. So can you tell us how this subsidy policy is supporting the financial protection of persons with disability in Lao PDR? From your field experience in particular, what do you hear from persons with disability in terms of access?
Hi.
Yes.
Hi, on. Can I speak loud? It's
I think
better
you can
to explain.
You can speak
more.
Lao, and we all need to shift to the interpretation in English. So you can use the interpretation button and switch to English for those who want to listen to the English interpretation.
Let me see for
On your site, Dr. Ketmani, I think you have nothing
yeah, I'm
to do.
looking
It's
for
only,
that one.
you don't need to change anything. You can just speak Lao, and our
Okay.
English Lao interpreter will automatically translate. It's for the participant to select the English interpretation. Thank you.
Thank you อยู่ในประเทศลาวเฮานี่แม่นจะเกี่ยวกับประกันสุขภาพการควบคุมของประกันสุขภาพเฮานี่จะมีค่อนข้างจะเกือบทั่วประเทศเนาะที่ว่าเข้าถึงการประกันสุขภาพของเฮาเนาะทั่วประชาชนทุกคนสั้นจะพบเฉพาะแต่คนพิการแต่จะมีแต่นครหลวงเวียงจันทน์เฮาก็คือนครหลวงเฮานี่จะบ่ได้ปกคลุมแต่ว่าจะมีประกันสุขภาพของภาครัฐและภาคเอกชนก็คือคนที่เรียกว่ารัฐวิสาหกิจก็จะมีประกันสุขภาพของเขาเจ้าต่างหากเนาะที่ว่าประกอบ มาปกคลุมแล้วก็จะมีอีกตัวหนึ่งก็คือสำหรับคนพิการคนที่อยู่เฮ็ดเวียกนำรัฐหรือว่าภาควิสาหกิจก็เจ้าก็จะมีประกันสุขภาพภาครัฐและภาควิสาหกิจทันปกคลุมตลอดเลยเวลาก็จะไปใช้การบริการอย่างในห้องหมอหรือว่าอยู่ในชุมชนต่างๆเนาะที่ว่ายามก็จะเจ็บเป็นแต่ว่าในกรณีที่คนที่อยู่ในภาครัฐหรือว่าเอกชนที่เกิดอุบัติเหตุหรือว่าพิการนอกวงเวียกพระเจ้าจะบ่ได้ถึกพระเจ้าก็จะมีส่วนหนึ่งที่ว่าบ่ได้ปกคลุมในการประกันสุขภาพแต่คนพิการที่ว่าอยู่ใน17แขวงที่อยู่ที่บ่ขึ้นกับนครหลวงเวียงจันทน์แม่นก็เจ้าจะเข้าถึงการบริการได้หมดทุกคนทั้งคนที่เป็นคนพิการและคนบ่พิการเนาะโดยการจ่ายเงินสมทบกับสถานที่บริการเนาะตามขั้นสั้นของตามขั้นแขวงขั้นเมืองหรือขั้นสุขศาลาเนาะตาม30,000 กีบ 20,000 หรือว่า 10,000 หรือว่าขั้น OPT ก็จะเป็น 5,000 10,000 หรือว่า 15,000 เนาะตามขั้นเลเวลของการจ่ายเงินครบสมทบเนาะอันนี้ก็เป็นอันนึงที่ว่าทางเบื้องลาวเฮาเนาะจะบ่มีการที่ว่ามีเงินสำหรับคนพิการเฉพาะนี่จะบ่มีเนาะจะมีแต่ภาครัฐที่ว่าคนที่เฮ็ดเวียกนำรัฐเฮาแล้วก็เอกชนบางจำนวนที่เพิ่นจะมีการจ่ายเงินให้เวลาเจ็บเป็นหรือว่าการบริการต่างๆแต่ว่าการบริการต่างๆนี้มันจะมีอยู่ในขั้นแต่ละขั้นของการอยู่ในตัวชี้วัดว่าเจ้าสามารถจ่ายอย่างใดแน่มันปกคลุมอันใดแน่เนาะบางอย่างมันจะบ่ปกคลุมคือสมมุติว่าคันคนพิการที่พิการตาบ่หรือว่าไม้ค้ำเท่าอย่างต่างๆนี่ก็เจ้าก็จะบ่ได้ปกคลุมเนาะหรือว่าอันล้อวินแชร์คือกันกับเจ้าก็บ่ได้ปกคลุมนอกจากว่าจะเป็นคนที่ก็จะมีโครงการที่มาช่วยเหลือเพิ่นจะแจกจ่ายให้เนาะสำหรับคนพิการเนาะตัวนี้นำโคฟบ่หรือว่าศูนย์ฟื้นฟูคนพิการบ่เนาะที่ขึ้นเพิ่นลงทะเบียนแล้วเพิ่นก็สิเอาแจกจ่ายให้ตามแต่ละบุคคลที่เพิ่นขึ้นรายชื่อเมียนเนาะแต่ส่วนใหญ่ก็อยู่ประเทศลาวเฮาจะบ่มีรัฐบาลเขาจะบ่มีตัวเฉพาะที่ว่าจะให้บางกรณีบางความพิการเขาจะบ่มีให้เนาะอย่างเช่นว่าล้อนิ้วบ่ไม้กันเท้าบ่ไม่รัฐเขาต้องได้อุปกรณ์ค้ำซูมอย่างต่างๆเนาะที่ว่าเพิ่นจะมีบางส่วนที่ผลิตได้ก็คือเพิ่นจะให้ก็คือมันคือขาเทียมแขนเทียมบ่เนาะสิ่งที่เพิ่นสามารถทางรัฐบาลเพิ่นสามารถประกอบส่วนให้ได้เนาะตัวนี้จะบ่ได้เสียค่าถ้าเสียก็ได้เสียน้อยเนาะสำหรับคนพิการเจ้าบ่แน่ใจว่ามันครบตัวนี้อีกบ่แล้วก็มีแล้วก็ส่วนใหญ่คนพิการอยู่ประเทศลาวเฮานี่แม่นเขาเจ้ายังบ่ฮู้ว่าสถานที่ที่เขาจะต้องไปรับการบริการเนาะอยู่บ่อนใดส่วนใหญ่แล้วแม่นคนอยู่แถวเขตนอกแถวหลายๆเขตเนาะอยู่หลายเมืองเขตนอกสิเขาเจ้าจะบ่ฮู้ว่าเวลาเขาเจ้าจะเป็นพิการหูพิการตาบ่หรือว่าพิการทางกายนี่เขาจะต้องควรไปรักษาหรือว่าไปรับการบริการอยู่หม้องใดส่วนใหญ่เขาเจ้าก็จะบ่ฮู้เจ้า that's all
Thank you, Dr.
Yes.
Ketmani. We will get back to some of the challenges that the country is facing in a moment. Now
Yep.
turning to Cambodia, Boravin. In Cambodia, one of the main way for persons with disability to access healthcare has been via the Health Equity Fund, Poverty Targeted Health Equity Fund. And a new initiative is currently underway with a disability card being rolled out. So can you share with us what are the experiences of persons with disability with the Health Equity Fund and with this new initiative of accessing care with a disability card?
Right. Thank you so much, Marielle. Before I start, I just want to make a little distinction between the Health Equity Fund and Disability ID card, because there have been some kind of confusion between two of them. So Health Equity Fund is currently the largest public health scheme in Cambodia that allows poor and vulnerable households to get access to free health services at public health facilities. But that, unless participants have to be eligible for ID pool identification as well, so it's kind of a double, like the dual system. Disability card, on the other hand, is an identification system for persons with disability, and it aims to develop a set of database for persons with disability in order to inform the design or the implementation of other social protection programs or social assistance program. So among persons with disabilities that we have involved in this study have been confused and have misunderstood that disability card is technically a social protection program, but I wouldn't say that it's a social protection program, but rather an identification program that facilitate with the design or future social protection programs. So going back to Health Equity Fund, the discussion and the result from the focus group discussion with persons with disability have informed that among Health Equity Fund members, mostly they have utilized the membership and actually go out to access to free health services. However, the number of members are limited as, for example, from the total sample size of 121 persons with disability in Cambodia, in this study, only about 21% have had access to the membership, and many of them have expressed frustration and kind of complaints about the evaluation of ID pool program being strict, despite the fact that disability is listed as one of the criteria in poor and vulnerable households. And on top of that, the Health Equity Fund, although it covers health medical expenses, it does not fully consider the costs associated with disabilities. So for example, a person with disability might need an accessible means of transportation that are hard to find or may be more expensive than a traditional means of transportation. They may need an additional assistant to take care, and they need to pay them, or meal allowances or other medical needs that they need to pay on top of that. So when not considering these aspects, it can leave very little room for persons with disability to consider to actually going and get access to healthcare. And so this is something that Health Equity Fund can learn from physical rehabilitation, because in terms of access to physical rehabilitation, it covers these additional costs associated with disabilities. So I think taking that into consideration, the Health Equity Fund can still have room to be more inclusive. Thank you very much.
Thank you, Boravin. And since you are talking about rehabilitation, I will keep you on the floor for my follow-up question, which is particularly about rehabilitation and assistive devices. So one of the findings of the research was that these services, when they are needed, they are mainly accessed through specific centers, oftentimes managed and dependent from NGOs and external funding. Can you tell us more about the experience of persons with disability in accessing these services? Again, acknowledging that it was not a nationwide survey, right? So we selected some specific location. But how could maybe the country consider pursuing a better integration between the public health system and the existing rehabilitation services that are outside of that system?
Right. So first, I'd like to give a general context of physical rehabilitation services in Cambodia. There are currently a total of 11 rehabilitation centers across the country. And I believe 6 of them are donors funded and 5 of them are fully government funded. And so the centers are currently being under management of Persons with Disability Foundation of the Ministry of Social Affairs. What's special about the physical rehabilitation services is that they provide free rehabilitation services to any person with disabilities, free of charge. And the persons with disability do not have to be members of any social protection schemes. As long as they have a disability, they go and register and they get assessed and they will be provided with physical rehabilitation services accordingly. On top of that, there are, like I mentioned earlier, there are additional benefits to rehabilitation services, such as transportation fees for persons with disability, meal allowances, and also free accommodation as well, because this kind of service is not something that can be done within a day. It requires a certain period of stay, and so it's great that they have additional support on top of that. Although they have additional benefits, there are currently, as I stated, only 11 rehabilitation centers in total across the country when we have 25 provinces. So that means persons with disability, some persons with disability have to resort traveling across provinces to get access to these services. And it can impose a barrier for them to actually get the service. However, there's been a rollout of mobile rehabilitation services by the Persons with Disability Foundation. The center actually deployed vans to go out and reach to more persons with disability in remote areas where transportation is an issue, or infrastructure is not accessible, or just to reach more population in general. So that is something that we see as an improvement. However, according to the key informant interview with the Persons with Disability Foundation, the capacity in deployment is still limited. And so they can't really provide a full physical rehabilitation services like in the center. So appointment will still need to be made. Direct visit will still need to be done, and they can only fix or do some maintenance on the existing clients. So that's the limitation of the services. Although I think in the end of 2020, the previous Prime Minister of Cambodia has announced the transition of physical rehabilitation centers, including the orthopedic factory and also the training school for the rehabilitation services, to be under the management of Ministry of Health. But it is currently in transition period, and that will be done within 2 or 3 year periods.
Thank you. No, thank you, Borevin. Sorry, I will have to interrupt you because I know we could keep going. It's very interesting, and particularly on that last point that there are ongoing reforms to integrate and further develop the rehabilitation services in Cambodia. And on the same topic, I would like to turn again to Dr. Ketmani. Dr. Ketmani, in Lao PDR, there is a similar landscape when it comes to the provision of rehabilitation services that are not yet fully integrated. Can you share with us what you have learned in the field study in that regard, and how you think these services could be better integrated in the system of Lao PDR? You can go ahead in Lao language, no problem. You're on mute, please. If you could unmute.
Yeah, sorry.
We can hear
my
you
voice
now.
is not good. Okay, I'm sick, so but yep. In Lao, what can I mean? Can you repeat again for the question? Sorry.
Sure. About rehabilitative services, the rehabilitation services, access to assistive devices. Could you share what you have learned through the field work on the access to these services for the persons with disability, and maybe the effort that could be done to better integrate this provision of services into the public system?
อยู่ลาวเขาจะมีศูนย์ฟื้นฟูคนพิการเนาะที่ว่าเขาจะสามารถช่วยได้2มาเขาจะมีสมาคมคนพิการเนาะอยู่ในระดับประเทศลาวแล้วก็จะมีสาขาอยู่แต่ละแขวงเนาะที่เพิ่นจะสามารถจะลงไปเฮ็ดเวียกนำได้และสามารถเขาจะมีองค์การของ NGO ต่างๆที่เพิ่นเฮ็ดเวียกเกี่ยวกับคนพิการเนาะเพิ่นจะบ่ได้ลงไปทุกแขวงเนาะแต่ว่าเพิ่นจะลงไปบางแขวงที่เพิ่นจะช่วยเหลือเนาะในการเข้าถึงให้สำหรับคนพิการในแต่บางแขวงเดี๋ยวนี้เพิ่นก็มีแนวทางเพื่อจะขยายเพื่อจะให้คนพิการเข้าถึงการบริการเรื่องสุขภาพนี้โดยเพิ่นจะได้มีหน่วยงานที่ว่าเป็นโมบายเนาะลงไปคันเมืองคันไปบ้านเนาะเพื่อไปเบิ่งซอกหาคนพิการและกับการให้ความรู้สำหรับกระเจ้ากับคนพิการการฝึกแอบของกระเจ้าหรือว่าเวลาเจ็บเป็นกระเจ้าต้องไปไสเพื่อไปรับการบริการเนาะอันนี้ก็มีกำลังขยายตัวไปแต่ละแขวงเนาะก็เริ่มมีประมาณ5แขวงเนาะที่ว่ามันมีโครงการลงไปแล้วเพิ่นก็ได้ลงไปเฮ็ดเกี่ยวกับเรื่องการโฆษณาเกี่ยวกับและการรักษาตัวเองการเบิ่งแยงตัวเองสำหรับคนพิการเนาะว่าสิจะเฮ็ดแนวใดมาก็จะพบปัญหาโดยเฉพาะคนพิการบ้านอยู่ประเทศลาวเฮาส่วนใหญ่ก็จะเป็นคนที่อยู่ในเขตชนบทส่วนใหญ่เนาะแล้วก็การเข้าถึงหรือว่าการเข้ามารับการบริการก็จะยากดังนั้นจึงเฮ็ดให้มีค่อนข้างจะยากในการที่จะให้คนที่พิการเข้ามารับการบริการในเขตที่ชุมชนเฮาหรือว่ามีการสถานการณ์บริการสถานที่บริการเนาะเรื่องอุปกรณ์การแพทย์หรือว่าอุปกรณ์การช่วยเหลือของคนพิการนี่ก็ค่อนข้างจะยากเนาะถ้าว่ามีการช่วยเหลือหรือว่าจากองค์การหรือว่าสิ่งที่รัฐบาลลาวเฮาบ่มีก็จะเป็นการดีเนาะลงถึงคันเมืองหรือว่าคันบ้านที่ว่าประชาชนที่เขาเจ้าเข้ามายากมารับการบริการยากคันจะเป็นการดีเนาะอันนี้ก็เป็นตัวนึงการโฆษณาหรือว่าการที่ว่าให้ทางวิทยุหรือว่าการบอกกันหรือว่าสายเรื่องพวกการแพทย์เฮาเนาะก็เป็นอันนึงที่จะเป็นให้กับเจ้าฮู้ว่าการบริการจุดบริการอยู่ไสเนาะก็เจ้าสามารถมารับใช้การบริการอยู่ไสและอีกตัวนึงเวลาคนพิการเนาะก็เจ้าจะมีความเรียกร้องต้องการตัวนึงที่ว่าก็คือก็เจ้าเวลาก็เจ้าต้องการเวียกงานเนาะก็เจ้าจะเฮ็ดเวียกงานก็เจ้าสามารถเฮ็ดเวียกได้เนาะก็เจ้าจะเฮ็ดเวียกนำรัฐเฮาได้หรือว่านำภาคเอกชนหยังต่างๆก็เจ้าจะมีอาชีพก็เจ้าสามารถเฮ็ดได้แต่ก็เจ้าอยากให้มีโอกาสให้กับเจ้ามาเฮ็ดเวียกนำอันนั้นก็แม่นตัวนึงแล้วก็เจ้าสามารถบอกต่อกันได้เนาะในการที่ว่าสามารถเข้ามาเฮ็ดเวียกหรือว่ากันมารับการบริการเนาะอันนี้ก็เป็นตัวนึงที่ว่าทางเบื้องลาวเฮาเนาะที่ว่าเฮาจะมีพบปัญหาหลายอย่างเนาะและบางอยู่ในประเทศลาวเฮาก็จะมีบางโครงการที่ว่าเพิ่นเข้าถึง การบางแขวงเช่นแขวงเสียงขวางบ่หรือว่าแขวงจับประซักเนาะเพิ่นจะเข้าถึงบ้านถึงคันประชาชนแล้วก็ถึงครอบครัวของคนพิการเนาะการบริการแนวใดก็เจ้าขอบใจค่ะ
Thank you, Dr. Ketmani, for your additional insight. I know we are running a little bit of time, out of time, but I would like still to give a few minutes for Dr. Fong for the last question also about the integration of these services. Vietnam has made some good progress in that regard. To integrate the provision, but also these benefits into the benefit package. Although not everything is covered, there are a number of rehabilitation services that are already included in the health insurance package. Can you share with us how effective this integration has been? And a question that is a bit different, if you can say a few words also about long-term care services, and what step, if any, have been included, have been taken to include long-term care services in health insurance benefit package? Dr. Fong, I think you're still on mute.
Yeah,
Yes, we can see you. Perfect. Thank you.
Yeah. So sorry, Maria, could you please repeat the
yes.
question again? I just missed. Yeah.
No problem. On rehabilitation, how has Vietnam managed to integrate a number of rehabilitation services into the benefit package? And can you foresee some next step for covering the cost associated with long-term care as well, knowing that Vietnam is one of the countries in Asia that is aging extremely fast?
Yeah. Regarding to the scope of the service to cover for the disability people, especially for the rehabilitation service, in the health insurance law, there's also the regulation that the rehabilitation also included in the scope of the benefit package for the member of the social health insurance already. It means that the people with disability having the health insurance card also eligible to have the medical and treatment service for the rehabilitation. However, the number of the service and the level of the technique for the service under the rehabilitation still limited. Especially at the lower level of the healthcare system at the district and on commune level. So I think that even there's the rehabilitation also included in the benefit package, but the effective coverage of service for rehabilitation still have the limitation because of the capacity to deliver the service at the lower level of the health system, as well as there's still the limitation because of the health insurance. That's also the list of the medical device and the procedure under the rehabilitation reimbursed by health insurance. So that is the positive list of the service rehabilitation service covered by health insurance. So that positive list still quite limited, not inclusive and approach list yet. So in fact, for the disability people who access to the health facility of care, they still have to pay out of pocket for accessing the medical service for under the rehabilitation. So that is about the medical and treatment cost for rehabilitation. Concerning with the device, assist device for the rehabilitation that not included in the health insurance benefit package yet. During the revision of the health insurance law, there are also proposal and the plan to advocate for expand the scope of the benefit package to include the assistive device for rehabilitation. But now there's some how can I say, delay for expanding the scope of benefit package under the social health insurance for this term of for this type of the revision of the health insurance law. So maybe we have to continue advocacy for this policy for the next time of the revision of the health insurance law. That is about the scope of expansion of the scope of the service, rehabilitation service, as well as the assistive device for rehabilitation. At the same time, there's also national plan to strengthening the national system for rehabilitation. So we aim to strengthen and promote the capacity in delivering the rehabilitation service at the all level of the healthcare system, especially at the lower level. So we hope that with that national plan and the initiative to expand the coverage of the benefit package of health insurance, so we have more opportunity for the disability people to accept the service as well as the assistive device for them. Yeah.
That sounds very promising, Dr. Fong. Thank you very much. We see a lot is happening, in fact, at country level, be it on the demand side through strengthening social health protection systems, or the provision side to increase the quality and the availability of the services. So it's time now for me to thank you all, dear panelists, for your rich contributions, which are very important to bring to this forum the voice and experience of persons with disabilities. It's now time to hear from Christine Phillips from the Australia National University, who will be discussing the Australia experience in building a national personalized disability support scheme. So Christine, the floor is yours. For our interpreter, I would just ask you to speak more slowly than we have done so far, because we are speaking too fast for the interpreters. Thank you very much in advance.
Thank you.
Okay, thank you very much for this opportunity to speak to you all, dear colleagues. I want to talk today about the Disability Insurance Scheme, which is a customised insurance program for people with disability. And this is a timely time to talk about this, as it's now hit its 10-year anniversary. This has been described as Australia's biggest social transformation of the last several decades. And it's timely to reflect on how it's worked and where we are looking for the next 10 years or into the future. Next slide, please. So in this short talk, I'll present to you a brief background to the NDIS, describe the model, describe how it's implemented, and then look at successes and challenges and the way forward. Next slide, please. The background of the challenge here was that 17% of Australians have a disability. It's about 4.4 million. And of those, only about half are in the workforce, and many of even children with disabilities, even though we have, of course, compulsory school, don't attend school regularly. And as has been described in other countries, Australia also faces a challenge with people with disabilities facing poverty. And amongst OECD countries in 2014, at the start of the NDIS, we ranked lowest. The physical disabilities, the disabilities are divided into physical and mental, and about 77% of the 4.4 million people have a physical disability, and 23% have a primary mental disability. Next slide. So what exists and has existed for a long time is a support pension mechanism which provides some kind of income stream. People who are on this pension are exempted from looking for work. That pension is regularly reviewed to see if people can work, and it's lost if the person returns to work. There are about 770,000 people receiving this pension product. There is also a pension for people who are carers, and these are overwhelmingly women. About 310,000 women, well, people receive carer payment, and then there is an income supplement, a carer allowance, and approximately 630,000 receive that. Next slide, please. Although the projections for disability support pension were that it would slowly increase, we are seeing real increases in the people receiving carer payment, which tells you something about the lack of support and services available to disabled people, in that people have to leave the workforce in order to provide care and support at home. Next slide, please. So a major inquiry into the state of disability care in Australia in 2011 stated that our existing situation was underfunded, unfair, fragmented and inefficient, and that there should be a new national scheme, the NDIS, the National Disability Insurance Scheme, that would cover all Australians in the event of a disability. And this would fund long-term, high-quality care and support, but not income replacement for people with significant disabilities. Next slide. This was received with great delight. This proposal for a national disability insurance scheme was received with great delight by disabled people themselves. And here they are protesting on the street. There were thousands of people who protested around the country in order for this disability pension, disability insurance scheme to be made, to be passed by politicians. First national demonstrations we've ever had, led by disabled people. Next slide, please. So the National Disability Insurance Scheme, which was launched in July 2013, is funded by government and by states out of consolidated revenue. It uses the WHO functional model of disability, and it provides a customised package of services to improve the functional quality of life. And these are in the areas of mobility, communication, social interaction, self-management, learning and self-care. It isn't intended for those with chronic illnesses. And importantly, it included psychosocial disability. So it included disability resulting from mental illness, which would affect someone's ability to function in society. Wasn't intended to replace state-funded services or supports. Next slide. It was fully rolled out around 2020. So across Australia, we've really only had 3.5 years experience with it. In implementation, it's oversighted by an independent statutory body, the National Disability Insurance Agency. People apply for access to it. They're assessed and interviewed, and then they're granted a package, which is called a plan, which includes some core supports and other supports. And they can either self-manage their plan or a provider can manage their plan. And through that, they contract allied health or home support or transport or psychological services, whatever is going to lead to the best functional outcome for the disabled person themselves. Next slide, please. So there are a number of challenges, and here I'll list them through. First of all, more individuals applied than expected. The Productivity Commission anticipated that 410,000 people had severe and enduring disabilities that would need this scheme. But in fact, already over 600,000 people have applied and are receiving the scheme. There were insufficient trained case planners to actually assess and interview people and to determine the kinds of packages that were needed. And next. Self-management, as it turned out, was often very time-consuming. In fact, only about 15% of people do self-manage their own plans. These new organisations that have emerged in the implementation period actually manage the plans. And these new organisations often had inadequate oversight because they were just emerging as often as fly-by-night organisations to meet the needs of people with disability. And in the markets they had to contract, sometimes there were insufficient services to meet the need. Some of the old markets atrophied as previous state-funded services for people with disability actually stopped. And there are thin markets, by which I mean there are markets in which there are groups of people who really, particularly people who live in very remote areas or Aboriginal and Torres Strait Islander people who really couldn't access the NDIS. In fact, overall, the NDIS has been much more has been taken up by people with resources, people who are educated, men, and has been less taken up by women, by people from culturally and linguistically diverse backgrounds, by Aboriginal and Torres Strait Islanders, and by rural people. Next slide. So 10 years into the NDIS, we have the last call, about 650,000 people enrolled. This little mark comes from an assessment of the projection from the National Disability Insurance Agency, which projects that by 2030 there will be over 800,000 people on a scheme that the Productivity Commission believed about 600,000 people would be on. It's been taken up with alacrity, and that has led to cost blowouts in the NDIS and discussions about how to ensure that the NDIS is sustainable into the future. Statements are being made that the NDIS may well cost us more than Medicare, which is our social health insurance, or the military. It has been transformative for many, and it's had this wonderful effect of making disability present in everyday life. Many, many young people now start their first working in disability care. These are positions and jobs that we never had before. In fact, I think a third of the new jobs that started in the previous year were actually related to the NDIS. So that has made disability everyone's concern. That's been very positive. Next slide. And this is another gathering of people to advocate for the NDIS. And the point I make here, this was made before a previous federal election a couple of years ago, in which there was concern that the NDIS, with its cost increases, was going to be curtailed. And there were demonstrations around the country, again, about defending our NDIS. And these are like the demonstrations we sometimes see about defending our Medicare. That is, it is now viewed as a social good. I don't think any of us who are watching the NDIS and watching it become bigger and bigger. All of us are supporting it and want it to succeed, and that would be the general view, I think, across the country. Next slide. So reflecting on the first 10 years of implementation, one of the challenges has been there's been a loss of service infrastructure for people who aren't on the NDIS, and the majority of disabled people are not going to be on the NDIS. It's not designed for all 4.4 million people. However, the states have defunded many of the previous supports for disabled people, and that has meant that more people have been forced to apply for the NDIS to get their basic services. We need better governance systems to ensure good practice by providers and to prevent fraud, as can sometimes happen in a rapidly growing scheme. We need cost and quality controls over services. We need innovations for thin markets, such then these are the people who are underserved. The most recent government review didn't mention gender at all, and yet, although disability is equally distributed along gender lines, a little over a third of people on the NDIS are women, so they are underrepresented on the NDIS. And we need capacity development for workers and planners and providers. So there's a lot more work to be done in this space, but it is a very exciting space, and it is starting to have that impact on social transformation, which was the dream, I think, of the people in the early days of the NDIS. Next slide.
Sorry, Christine, that will be, I know it's the last slide, if you can summarize it in a minute. Thank you.
Yes. So considerations for the future are, an important thing is the psychosocial disability, which is a unique category and poorly defined. And at the moment, about 30% of people who apply for that are rejected. And there are, as before, few state-funded services. They have been scaled down. So this is people with disability resulting from mental illness are really underserved at the moment. Needing to respond to autism diagnoses, which have escalated in Australia. Significant administrative burdens to be managed, and we need to monitor and manage emerging markets. That is my last slide, Marielle. So the next slide is just a thank you. Thank you to everybody for listening to this. I'm really enjoying this webinar, and if anyone wants to contact me, that's where I am.
Thank you for this excellent presentation, Christine. You have comments, in fact, in the Q&A box as well from people who would like to know more. So we may get back to you during the Q&A session in a minute. Thank you very much again. And I will now invite Alexandre Cotte from UNICEF to make his presentation on assistive devices. The floor is yours, Alex. Thank you.
Thank you very much, Marielle, and thank you everybody for the discussion so far. It's extremely timely, extremely useful. I'm in Dakar right now on a symposium on the inclusive resilience and access to healthcare for persons with disabilities, really at the center. So I wanted to briefly talk about the role of social protection in access to assistive technology in low and middle income countries. And first, I wanted to share some of the result that we got in doing disability cost study for children with disability in Georgia, which shows that across the diversity of persons with disabilities, so the graphs show the cost for children with disability of different groups. I won't go into the detail, but what's really striking is that assistive technology, which are the blue bar for all in all the columns, for all the groups, while it's quite diverse for every group, for each group, it's basically there for every group. Whether we talk about person with physical disability, intellectual disability, hearing, sight impairment, etc., AT is there for everybody, and it's needed by everybody. We know that assistive technology is critical for health functioning, autonomy, and participation from childhood to older people. Many older people need assistive technology while they would never self-identify as person with disabilities. We know they are an enabler for access to education and employment. And they are also assistive technology and products reduce the need for unpaid care and support, which is disproportionately provided by women and girls in household. And there is a very clear return on investment. AT 2030 and ET scale, we did this return on investment analysis. For $1 invested in access to assistive technology, there is a $9 of socioeconomic return. So connecting AT to social protection rely on different aspects. The first one is AT is not necessarily the biggest cost related to disability. Human assistance, and we just had the example of NDIS, as well as healthcare, everything that we've been discussing so far, are clearly the major driver for disability-related costs. But we know that AT can be a one-off significant expenditure that either people cannot afford or that will lead to catastrophic expenditure and indebtedness, etc. The CRPD committee has repeatedly encouraged government to cover disability-related costs through social protection with specific reference to assistive technology. But as you know, in most low and middle income countries, people with disability rely on out-of-pocket payment and support by families to procure AT. And the great report from WHO and UNICEF 2 years ago really showed evidence of this. So if we look at how it works in high-income countries, social protection systems through social health insurance or dedicated schemes cover many of the assistive technology. The issue in low and middle income countries is that, and we heard the challenge of access to healthcare and coverage, but there are also issues in disability-related social protection. So if we connect AT to disability-related social protection, today, in many countries, this will be limited in terms of impact. But we see that a growing number of countries are seeking to cover healthcare costs of persons with disability. We get great example from Laos, Cambodia, and Vietnam through different schemes and try to include assistive technology, for instance, in universal health coverage or health insurance subsidy. But often there is a very limited scope of assistive technology and products, and there is a very long waiting time to access the device. Several countries have set up specific programs, very often connected to the Ministry of Social Welfare, or they are independent bodies, but still financed within social welfare to improve access to AT, but again, with a limited coverage and scope. So one of the things that is important also, and we talked about it a bit earlier, there were some questions, the accessing AT means getting the information, means having probably a disability allowance or concession for transport to reach the rehabilitation centers or the places where I can get AT in the first place. And so the logic of the diversity of schemes that are required to help accessing AT is not only the coverage of the cost of AT, but ensuring that people have support to be able to get to the places where AT is provided. But we have a risk of a double exclusion when we think about social protection in relation to assistive technology and persons with disabilities. In many countries, social protection for persons with disability has a kind of double targeting. The first one is the disability card or the disability assessment and determination mechanism. Charles mentioned it, and we heard about the great progress in Vietnam and Cambodia to that regard. But still, we know that in most countries, in low and middle income, many people with disability do not have disability card. In the other hand, poverty targeting of disability support, we know, and it's inherent to poverty targeting, it excludes a lot of people who may need assistive technology, but basically would not be eligible because they fall out of the poverty targeting. And when you do disability card and poverty targeting, basically you magnify the risk of exclusion errors. And this debate of whether assistive technology and products should be subsidized or free only for people that have a disability card or for anybody who needs it, is really one of the core discussions that we have. UNICEF is definitely in line with WHO and ILO in trying to promote the most universal access to assistive technology within universal health coverage. But there is an understanding that in some countries that are nascent system of universal health coverage and nascent social health protection, there may be a need to prioritize first people who have disability card, but very careful consideration need to be given whether this is what could be the unintended consequence of doing so. So what's the way forward? Different things are being done. First, and we've seen with Cambodia, there is a greater coverage of disability assessment and certification mechanism, which is really positive. And it's really something that we see in many more countries. And there is also many countries that are shifting more and more to a broader and universal social protection for persons with disabilities. So those evolutions can contribute to a better access to social protection. And if 80 is connected also towards 80, but it doesn't eliminate the risk of exclusion from needed support. So there is a strong rationale for most assistive technology and product to be included in universal health coverage, not the least because of holding aging population. And as I said, many older persons will not request disability card because they don't self-identify as person with disability, but they still need assistive technology. So there is a strong rationale, but there may be reluctance from social and health insurance bodies to take the sole responsibility for covering the cost of assistive technology. And we see a model that is emerging in many countries where you have an increasing inclusion of most common assistive technology, especially in relation to the priority assistive product list from WHO, which is helping countries to set this list, in the UHC package, accessible to a wider diversity of persons with disabilities, whether they have the disability status or not, together with the coverage of more specific AT, more expensive, for instance, electric wheelchairs, that would be covered by specific disability-related schemes or under the condition of the disability card. And we see that such approach could actually distribute the cost of expanding access to assistive technology across different ministries. One ministry also that I didn't mention, but is important, is the Ministry of Education with regards to assistive technology related to learning. And we see more and more Ministry of Education that are also providing assistive technology. So we see that there is this scope of possibilities from social health protection, specific disabilities social protection scheme, and education, all connected, that could significantly increase access to assistive technology. Thank you.
Thank you, Alex, for this very insightful and I would say even thought-provoking presentation, particularly when it comes to the limitation of the disability cards. But also for sharing some specific way forward and strategies that countries could consider. We have seen today that some of the countries in the region in Asia are now revising their laws on social security or health insurance, thinking about implementing a number of costing and revision of benefit package, and these resources and strategies will be extremely useful for them. We are almost on time. I would like now to welcome Mr. Lim Poitiak for his insight and for sharing his experience from the ASEAN Disability Forum on that topic. So the floor is yours, Mr. Lim, please.
Thank you very much for inviting the ASEAN Disability Forum to share our views and our insights into this very vital and important topic that we have. And what we did to prepare for this discussion is actually to bring together, because we have focal points in Vietnam, in Cambodia, and in Laos, and I've kind of gathered their views on the issues at hand. And I feel that it's important for us to really understand, because from the perspective of the OPD, this is where I think reality meets theory, because so much has been very well articulated by our presenters and our speakers today in terms of the policy, in terms of the survey, in terms of the findings, in terms of what governments plan to do for a more comprehensive healthcare coverage in these three countries. Many are already moving towards more disability inclusive policies. Some are work in progress, and I think the feelings at the ground that I gather from our OPDs in these three countries are basically quite similar. Number one, they find that the facilities, whether at the regional level or at the headquarters level, most of the healthcare facilities are actually inaccessible to persons with disabilities. And I think although work is in progress to make these venues more accessible to people with disabilities, especially those who are wheelchair users and in need of assistive technology, we find that many of them are unable to access the services because of accessibility issues. Number two, many of them find some of the costs to be quite prohibitive, because as been elaborated earlier about the disability card and the healthcare fund and all these things. Many of them perhaps misunderstood the financial co-payment scheme that they may have to be involved, and many of them are unable to pay their co-payment sum. And some of our members at the focal points in these three countries gave us the feedback that many of their members are unable to afford not only the healthcare services, but also the assistive technology, the devices that they may need to use or purchase for their use in order to enhance the quality of life in the activities of daily living. The third point that come across very strongly from our members in the focal points of these three countries is that many of them are actually misunderstood or miscommunicated, and they have to face the brunt of the healthcare providers, the service staff, who may not understand their needs, who may have perhaps some preconceived ideas about their disability and do not understand the nature of the disability, and they actually felt that that there has to be a way, especially our hearing impaired members feel that there's a very lack of communication, because there's no sign language interpreters, or even our friends who are blind. They are not able to access information readily, and they are always in a very sad situation whereby communication gaps exist, and because there are communication gaps, prejudices and misconceptions and miscommunication flows very well. I think our friend in Cambodia brought up this remark from WHO in 2016, which is a bit dated, but I think the impact of that statement is still exists very well. He said, in general, persons with disabilities are more than twice as likely to report finding healthcare provider skills to be inadequate, 4 times more likely to report being treated badly, and nearly 3 times more likely to report being denied care. And I hope 8 years ago, this statement was made, and I hope that this observation would have been improved since that time in Cambodia. And many of our friends felt that the root cause of of this observation is because there's actually a lack of quality healthcare services, and there are some degree of discrimination and negative attitudes of healthcare workers. And again, mention about the lack of funds that has been allocated to provide adequate healthcare facilities and services for persons with disabilities. Our friend in Laos felt that persons with disabilities have poorer socioeconomic conditions and more limited opportunities compared to those in the population without disabilities, and they feel that they are in a way discriminated, and they want a fundamental change. And again, the feeling is that because of this lack of funds to support healthcare for persons with disabilities, in most places, healthcare facilities are inaccessible, and for those with hearing impairment, communication is difficult due to limited or no sign language interpreter. The situation, our focal point in Vietnam is a little bit more positive, and she observed that although there's no home-based healthcare service for people with disabilities, the Vietnamese Ministry of Health is the first ministry to gradually, progressively build an inclusive medical examination and treatment. And this includes a protocol on how the people with disabilities, when they come to a medical facility, they will be given priority, and the necessary assistance and care is extended to these people. And many of them felt that in Vietnam, that what is very heartening is that whenever there is a change of policies, or when you want to introduce new policies and law amendment, they would always make it a point to conduct meetings and consultations with persons with disabilities and their organization. I think that is a very positive way to foster a better understanding, better communication between the service providers as well as the service users, the people with disabilities. That's all I got to say. Thank you.
Thank you so much, Mr. Lim, for this intervention. We really much appreciate that you have reached out to your focal points to gather additional insight. And you have made a very important point just now about the participation of persons with disability in the design and the implementation of disability inclusive social protection system, including health. That's something we touch upon in the research that was presented, but we couldn't cover in depth into that webinar today. So thank you for bringing that very important point to our forum today. Finally, it's now time for the Q&A. And I will now turn to my colleague, Yuta Momose, who has collected your question through the Q&A box. Yuta, you can please proceed with the Q&A. Thank you.
Yes, yeah. Thank you, Marielle, for giving the floor to me. And then I think 10 questions we have received, and then 9 questions have already answered by some of the speakers. And then remaining is only 1, and then we have 7 minutes. So if some of the participants, if you want to ask some more questions, you can always write to the chat box, and then, or you can raise hand, or I mean, if you want to directly speak up. So in the meanwhile, I will be answering the last question, 1 remaining question on the Q&A box. Can we have handouts, please, and especially on the research result? Thanks. So regarding this one, now this webinar is kind of like gathering the feedback about our research, especially on the Cambodia, Vietnam, and Laos for accessing social health protection for the person with disabilities. And then now we are finalizing the report based on the comment that we are receiving. And then we plan to publish that report at some point of September or October this year. So we will definitely broadly advertise through our social media or any other ways. Then this question is answered, and then if somebody want to come in for any other questions that any other participant have, we are so much welcome to.
Or may I suggest we had indeed very interesting questions in the Q&A that were answered, but I think we can give some light to some of them. We have, for instance, a question from Ilaria about the exclusion of non-medical costs for the reason that health insurance systems tend to focus only on medical expenses and how that could be addressed. Charles, would you like, you have answered in the narrative, but would you like to say a few words, maybe together with Alex on this?
Yeah, so that was a question around the non-medical expenses. I mean, I think just at a top level, the key point is for those non-medical expenses such as costs of transport, costs of those kind of indirect opportunity costs. I think in theory there are many channels, and I think it will depend a lot on the national context and how our systems are being built. But yes, social health protection packages can cover some of those costs. There are examples that will be in the report in the 3 countries of transport, for example, being covered at different levels in different ways, including, for example, in access to rehabilitation centers in Cambodia. So that can be included. Secondly, I think it comes back to this point on cash benefits and cash transfers that I only mentioned briefly, and Alex also referred to, that, you know, many countries, let's say including Vietnam, but many others are introducing disability cash benefits that are seen as having a function of covering some kind of diversity of disability-related extra costs. So one, I think, can conceive that is at least making some contribution to, say, transport or some of the other costs that persons with disabilities may have, the increased frequency of having to access healthcare. So there's a contribution there. And then, of course, there's all kinds of factors in the kind of wider environment that influence those costs. So, you know, having a more accessible public transport system can reduce those costs. Having a subsidized public transport system, equally having a broader availability of services, so somebody doesn't have to travel for many hours or across the country to go to a rehabilitation center. So I think it's a combined effort. How that looks in a specific country will obviously depend a bit on your starting point and what are the best entry points for building that.
Thanks. Please.
Yeah, maybe Maria, I just wanted to add, especially related to the progress that we've seen, for instance, in Cambodia with the DMIS, it's how disability assessment that is made can flag issues. Who are the people that are the most likely to face barrier in access to healthcare, for instance, and what kind of arrangement can be made for that? And this is where I feel that, and it may be science fiction in many countries, but we are getting there, and I think many countries are leapfrogging. It's how do we move from disability assessment and certification to a case management approach? Again, this is very nascent, but we see, for instance, in Laos, the work around the OCAL program and community-based inclusive development, connecting assessing needs of people with disability and trying to facilitate this access of healthcare. So there are third-party players like NGOs working or OPDs working on community-based inclusive development that can help identify some of those barriers and try to address them. But I feel that it's extremely important to have this awareness of the diversity of costs and barriers that are not only the medical costs. And now we need this progressively comprehensive approach to address them. Thank you.
Thank you, Alex. And I think it's, in fact, an excellent conclusion for our webinar today. I would like to thank all of you who have been speakers, panelists, or participants with a lot of very meaningful questions. And last but not least, I would like to thank very much all our interpreters who did a great job today. So thank you very much for your active engagement. It has made this event very meaningful, and all these inputs that we have gathered today are also going to be very useful for the finalization of the report Charles presented, a report that will be shared with all of you early September. So thank you very much, and we look forward to seeing you at future events.
Thank you.
Thank you.